And I wish to thank everyone that has joined us. This Zimbabwe Health Cooperatives Stakeholder Meeting is following a series of stakeholder meetings we are having in the sub-regions of Africa. So today we have one for the Southern Africa, and this is being hosted by Zimbabwe. So we really thank you, Zimbabwe, for agreeing to host the stakeholder meeting, the Health Cooperative Stakeholder Meeting. Now, for those who have joined us, the stakeholder meetings arise from a conference that ICA-Africa held in Zimbabwe last year, May of 2019, where they were focusing on SDG number 3, that is good health and well-being. And it was to see how cooperatives can contribute to that SDG, focusing on how African cooperators could get into health cooperatives or health matters, both for their members and their communities. So that's why we, as ICA-Africa, the members of ICA-Africa and other stakeholders have decided to embark on this series of stakeholder meetings in each country. Now, to start us off will be Mr. Mike Duru, who is the board member for ICA-Africa. You start us off in this meeting, welcome the participants, and then welcome the speakers in the following order. We'll have Ms. Beauty Marimir, what a nice name. And then we have Dr. Enoch Tatira. Then we shall have Dr. Chris Chivinge. Then Dr. Dan Atuwide. And then followed by health partners who are our members in Uganda, and also our good friend Jennifer, who is representing health partners of USA. So thank you very much. I wish to welcome you all, and I now invite Mr. Nduru.
Thank you. Thank you, Rose. Ladies and gentlemen, good afternoon. May I start by recognizing the ICA President, Mr. J. Mangomere, if he is present or in absentia, and the other board members who are present, ICA Regional Director, Dr. Sifa, and the staff, ICA staff Africa, government officials present, our speakers, stakeholders, and the dear cooperators. It is my pleasure to welcome you to our health cooperative meeting, which is being held via Zoom due to the COVID-19 pandemic. The meeting is the third after the Kenya and Nigerian ones, and seeks to provoke cooperatives in Zimbabwe to start health cooperatives. According to ICA and the B20 figures, 100 million households worldwide enjoy access to health care from cooperatives. There are 3,300 health cooperatives in 76 countries in the world, with an overall turnover of $15 billion. Health cooperatives are in many forms, as given in the following examples: worker or doctor cooperatives, which generate employment on decent terms. Example is those that are in Australia. Cooperatives managing hospitals and healthcare facilities and institutions dedicated to disease prevention. 3, health promotion cooperatives that train staff and patients. 4, distributor cooperatives of pharmaceutical products. 5. Health insurance cooperatives. 6. Production cooperatives. These are mainly in Belgium, Spain, and Italy. Having given these examples, it is worth noting that all these healthcare cooperatives share common goals. Among them, to bring together health professionals and users so as to reconcile misalignments between healthcare supply and demand. To enlarge all stakeholders involved in healthcare to jointly manage costs, risks, and to achieve the utmost quality in care provision. User cooperatives manage their own care services. These are mostly found in Japan, where we have 111 cooperatives representing 2.92 million cooperators. Also, you get these user cooperatives in Singapore, Argentina, Canada, and Brazil. And Brazil has the largest cooperatives in health care in the world. This health cooperative stakeholders meeting today has come at the right time after United Nations, during its 74th session of the General Assembly this year, made special mention of cooperatives being one of the best enterprise models to use in helping in the development of the health sector. They talked of cooperatives in social development, a clear acceptance of the cooperative model of doing business by the highest global board. In Africa, we have very few health cooperatives as compared to America, Europe, and Asia Pacific. This lagging behind is attributed to the following 3 main points. 1, knowledge gap on roles and responsibilities cooperatives can do in the health sector. Number 2, absence or inadequate policy or policies that support cooperatives in the sector. The last one, the issue of partnerships. Cooperatives might not have financial muscle and need partners like private sector to venture into the sector. They need partnership for technical support. They need partnership for best practice sharing. However, countries like Lesotho, Kenya, Rwanda, and South Africa are doing a lot now in the healthcare sector in villages where they are providing basic primary health care services to individuals within designated villages through savings and credit schemes. In Zimbabwe, there are no healthcare service cooperatives. This is an opportunity for Zimbabwean cooperatives to venture into the sector and provide cheap but quality healthcare services to the people. It is upon ourselves as cooperatives to take up this challenge, have confidence in ourselves, and contribute to the United Nations SDG number 3, good health and well-being for our nations. With the increasing number of diseases in the world and aging, governments alone around the world cannot manage. They need partners. We are one of the best partners. In conclusion, may I urge all cooperators in Africa to take such meetings and experiences seriously. Let me thank our regional director, Dr. Sifa, and a team being led by Dr. Rose for organizing such a timely and good meeting. Cooperatives, believe in yourselves, form partnerships, and provide the much needed health services to our communities. Once again, I welcome you to the meeting. I thank you.
Thank you very much, Mr. Duke, for that well-researched speech. Indeed, cooperatives need to believe in themselves. They already do, but they need to improve the belief in themselves, in that they can also provide healthcare, not only for cooperators, but also for the community at large, and become partners with all stakeholders willing to partner with them. So next, we shall have our first speaker, who is Mrs. Beauty Marimira.
Mrs. Beauty Marimira, Managing Director for High Ground Legal Aid Society. I just have 3 messages to share with you on this platform. My messages are what we do. Number 2, strategic partnerships with health cooperatives and their membership. Number 3, creation of health cooperatives, linkages with microinsurance companies. So, as I have already said, that I am the managing director for High Ground Legal Society, coming from the company sector. So, as High Ground Legal Aid Society, we offer legal insurance to individuals, families, and corporates by cushioning them on the unforeseen legal issues that may arise. Slide are not. Sorry. So
You can continue. We can hear you, Doctor, sorry.
Okay, thank you. My name, like I said, is Dr. Enoch Tatira. I'm a general practitioner. I'm based in Mutare. I, at one point, was the Zimbabwe Medical Association president for 2 terms, and before that, I was president, the vice president for another 2 years. So I would simply say for a good 8 years, I was at the helm of the medical associations which are affiliated to the Zimbabwe Medical Association in Zimbabwe. And during that time, I had a fair share of, I'm noticing the problems that our people were experiencing in terms of getting medical assistance. And as a result, I then came up with something called Access Health Medical Fund, which is in response to the suffering that we noticed, the deprivation in terms of medical services, as well as the impoverishment that our members were going through because of the traditional medical aid model of funding. So I will take you to my presentation, and if you can allow me to share my screen. Basically, what it entails is that many developing countries have been without a well-structured model of health funding. And this impacts negatively on the health and the economic productivity of the people living in these regions. And the level of economic development of a country is directly related to the type of diseases that can still inflict the people who are living there. If you are talking of cholera, you are talking of typhoid. These are diseases that we find in these countries, but they are nowhere, to be found in well-developed countries, so to say. And in these countries, most of the people pay for medical services out of pocket. And in most cases, they present late for treatment. That means that the condition would have actually complicated, which will gobble even more resources to manage. And they actually presented few under-equipped health institutions, which means that by the time they are going to present to these institutions, these patients are, who would need more specialized care in most cases are not going to get it, because the places where they are presenting to, the hospitals that they are presenting to, cannot cope with the type of conditions that they present within. As a result, we end up with losing more of them. And to make this even worse, these health institutions are located far apart, and that's far away from many people. When an institution is far away from the people that is supposed to serve, then the issues of access actually come into play. And I think before I go into the meat of my presentation, I thought maybe I should share with you the health funding models that we find under the sun. And we should know that each country designs its own model that is suitable to its particular situations. But generally, people fund for health out of pocket, although or through some form of medical insurance. And these fall under the following groups, which are what we call the NHS or the beverage model, the Bismarck model, or the national health insurance, which is a combination of the beverage model and the Bismarck model. Actually, by and large, I think what you should capture from this presentation is that a good model should meet 4 basic goals, which are to keep people healthy, to treat the sick, to protect families against ruin from medical bills, and reimburse service providers satisfactorily. And if they can, then they should generate some surplus. But the main idea is to make sure that the processes go on without anyone being prejudiced in the relationship from the service provider to the patients and who are the members of the fund. But there's no one country that applies one system alone. And there's need to contain costs and offer quality service and have strong regulatory systems. You know, when there are poor regulatory systems, you find fund managers actually failing to own up. You may find service providers doing their own thing, which is against what would have been agreed during the formative stages of the process. And as a result, the people who suffer in the process are the patients. But once that happens, then it means if you do have poor regulatory structures, then anyone will do whatever they want to do. And in some countries, people prefer to buy funeral insurance because medical insurance is can no longer deliver. There's something called primary health care, which was adopted as the preferred model of delivering health and health products to people by the World Health Organization. Its goal is the attainment of better health for all, which is called universal health coverage. And it is founded on equity, access, empowerment, community self-determination, and intersectoral collaboration, like what we are trying to do here. We have so many sectors that are collaborating on health, and in this case, under primary health, as a model of delivering health to the people. We are, in other ways, fulfilling one of the pillars of primary health. And it encompasses the understanding of the social, the environmental, economic, cultural, and political determinants of health. And unfortunately, in Africa, if we continue on the current trajectory, because of so many reasons, many developing countries will not achieve universal health coverage for a very long time to come. But what is the current status of health funding? And this is almost universal in Africa. I was listening to one presentation before where you would find generally, I think about 10% of our population have got some form of medical insurance. In Zimbabwe, this is about 5 to 7% currently. And at the best, maybe you can go as far as 10%. And then the current fee for service is not working anymore in many situations for a myriad of problems. And one of them is economic, so one of them is the level of industrial development that the countries are going through. And this exposes the fund managers to lots of variables and a huge insurance risk. You may find some people over-servicing, which is a bad thing, but yeah, I mean, people will be looking for money. The more people they see, the more money they make. So if they don't see anyone, they don't make any money. And sometimes sitting, watching and doing nothing is not the best thing that people would do. So there's also need for, therefore there's need for innovative thinking, like what we are doing with the ICA-Africa. But why would one want to venture in health funding? I think there's something that says that if you want to, once you carry your own water, you will learn the value of every drop. So if we involve everyone who is involved in the process, then at least we know why we are doing what we are doing and why we should not do what we are not supposed to do. But I think by and large, I mean, many of service providers and patients have been victims of the current fee-for-service model. We have lost relatives, we have lost colleagues, I mean, who became depressed and left either for the greener pastures or otherwise are actually patients themselves because of the economic burdens that they ended up having to face. You know, you want to change I mean, professions at very last, which is almost impossible. We were also told that we, as service providers, we should stick to treating patients while the medical funders were actually encroaching in the niche of service providers. You know, in our country, Zimbabwe, at the moment, you will find almost every medical aid society has got, it's running its own clinics. And deliberately so, they may not pay you what is due to you because you are in competition with them. They would rather see the patients and then the money is recycled within their system. But we can't do, like I said, if you carry your own water, you will know the value of every drop. Fine. Then it made me try to think outside the box. And he said we have the option to decide on a health funding model we can apply in our own environment. And the ingredients are there. And these are the patients or members, the service providers, the health institutions. But they need coordination through a funding vehicle that is acceptable to all, because that model should be able to deliver. And service providers have generally endured the following. They have been working without being paid or being paid, without being paid or being paid what the medical aid wants to pay as and when they want to pay. And they were also going through the trauma of seeing patients being discharged prematurely from hospital. And what it means is that they should go and die at home because they have exhausted their global limits. There's so much distress of being told how to practice medicine by a person who is practicing his or her own profession without anyone dictating on them. For example, you get restrictive use of resources that do not go along with the clinical challenges, which naturally differ from patient to patient. You are doing some surgery on a patient and you are told you are supposed to use maybe some 3 or 4 abdominal swabs, when in actual fact, that case that you are managing would require you to use maybe 8 or 10. But then the extra swabs that you are going to use are not going to be paid because you have exhausted the limits of the upper limit of 4, which is very unethical. But we had no choice but to birth an alternative health funding model, which we think works well to patients and their service providers. And we named it Access Health Medical Fund, correctly so, because patients should have equitable access to health care. So Access Health Medical Fund is a health fund modeled around capitation as the preferred model of reimbursement to service providers. I was talking about fee for service. Now we want to change and then introduce capitation. And our mission is to make sure the following will happen, that we should be able to keep people healthy by encouraging wellness programs and actually paying for those programs. I mean, currently, these wellness programs, by and large, are not being paid for by medical insurances. But we want to prevent people from getting sick. And if we want to achieve that, then we should invest in wellness and pay people who are actually practicing wellness, activities, services within the community. And we should be able to treat the sick. If we can't, then there's no reason for being in existence. We don't want to see patients being discharged out of hospital because they have exhausted their global limits. It doesn't tally. We want to protect families against financial ruin from medical bills, and that the service providers at all levels of care are paid in advance for the services that they provide to their patients. So what this is the services are being guaranteed. I mean, when the patient goes to see their provider, they would have paid for them in advance as a group, as a cooperative, so to say, to use your language. So much that when each member of the group or each member of the cooperative falls sick, the other people will take care of the bills, and together, it's like the few who are sick are being looked after by the majority who are not. And we would want to create pillars of service which will function independent of each other, and thus avoid spreading risk across the funding chain. As a primary care service provider, there are things that you get exposed to, which are happening in hospitals, which will actually milk all the money, and then we leave no money for primary care. But then you find the primary care is not consuming as much as secondary or tertiary care. But then the whole chain is affected. So we want to have pillars which will manage each activity, each level of care, and then we would then know where to increase in terms of subscriptions, being guided by the information that comes on from the industry. We want as well to, and we don't want to unnecessarily expose service providers in the process. Like I said, you make claims from a medical insurance, and then they will tell you we don't have money at the moment, and you wait until you get some money. And this service provider is being exposed, and if you had borrowed some money elsewhere, and you would want to pay back, it means he also cannot meet his obligations, and legally they are liable. And consequences will come whether they are paid or they are not paid, because they would have gone into a contract. But by and large, we want to make the family physician, who is the GP, the general practitioner, to be the center of care of patients. You'll see why this is important as we go. So if you see this logo in future, this is our logo at Access Health Medical Fund, and we hope we are going to color the whole of Zimbabwe and then go regional, because we think this is what is lacking. And in any case, some service providers that we have been talking to, and in the modeling of this fund, are really in agreement to it, and most of it, maybe we still have a few gray areas in terms of the quantum of money that people will pay. But we are being guided accurately, and we hope we will convince, in any case, we are actually convincing our service providers to see things differently. These days, money is not supposed to come in thousands of dollars from one person, but smaller amounts that will come from a number of, from so many people using economies of scale can make a difference in the way we manage each other. So, I will quickly go through this. Under Access Health, we have got something that we call the bronze pool, which will cover consultation and prescription to the consultants, to specialists. Then there's something called the gold pool, which covers the consultation, prescription, and the medication. Because we are looking at what people really want when they actually visit doctors. So they will need a consultation, then they will end up having to buy medication, or they may end up in a hospital. And then the one that covers the hospital is called the diamond pool. So basically, that's what things are like. This is the relationship that we are looking at. And I think it is important that we realize that under Access Health Medical Fund, we are run by a trust in terms of governance. And then we also have got a fund administrator and people who are doing marketing. And lower down, we would then have a pool of service providers. I didn't include on this slide the patients who are supposed to be the members, so to say. But otherwise, we want to manage our governance issues, and this is a problem that would sometimes derail initiatives like this. We really want to understand each other, who should be doing what, at the end of the day. So our fund administrator is called Zimbabwe Private Limited. It's a company, and we're being marketed by a company called Masco Medical Suppliers. And of course, we then have a team of service providers. Now I am stuck. It can't.
Move the button.
Can you see my screen?
Yes, you've gone to the next slide.
You can see it.
Yes.
Yeah, sure, fine, it's okay. Then I'm moving. So then, I mean, we around each family physician with a GP, we would have a nurse practitioner, we would have a nurse practice, we would have specialists around them, we would have pharmacists. Then we do have, I mean, a number of nurse practices around the physician. And then the physician will then, the family physician, so to say. Then the family physician then will refer to specialists on a need basis. We would want, everyone to end up, to go, to specialists with the flu. Let that be managed at a nurse practice because they can treat a flu. But if it complicates, let it go to the family physician. And if things have worsened up and the family physician cannot manage it, why can't he refer to specialists? So the chain becomes very clear. Everyone then will be doing what they are supposed to do, rather than what is happening at the moment, that a flu can be managed by a specialist at very high cost, and it makes health inaccessible at the end of the day, or it makes health so costly because we are managing conditions at levels that they are not supposed to be managed at. And then I then gave an example of a general surgeon who will have a group of GPs who are referring to him some patients that they need the general surgeon to manage. So what will happen to the physician, the orthopedic surgeon, the dermatologist, and anesthetist, O&G, and pediatrician as examples. They will have, these GPs will actually working with a team of specialists. And then the majority of the GPs, the patients then are going to be seen by these specialists in a way that warrants them getting there, because the GP cannot sit on the patient. If he cannot manage the patient, then they have to refer to the specialist. So if that happens, if the chain is maintained and it's managed properly, you'll find that the cost of managing the process, the relationship becomes easier and cheaper. What then it means is that if suppose we have got 10 GPs or maybe 20 GPs, each of whom is looking after 10,000 patients, it means we do have some 200,000 patients who are actually going to be seen by a general surgeon. And getting or raising money from 200,000 patients every month, even if you say each patient pays 50 cents, it means you raise about $100,000 that you can give to that general surgeon. And it's money that goes to the surgeon every month in advance before they see the patients. And when they see the patients, then they have, through our contracts that they sign, they are not supposed to turn away any patients or charge any extra money, because they would have been paid in advance anyway. This is how it works to the physician, to the orthopedic surgeon, to the dermatologist, the anesthetist, the O&G and stuff. But there are other specialized specialties like neurosurgeons, for example, where you want to ensure for very costly services, you underwrite them with an insurance company. So much that when for example, you get a head injury, and then the patients will need to go to theater. They'll go to theater knowing for sure that the monies are coming through the insurance firm that you would have underwritten such an eventuality. So we basically we are saying 80% of our revenue goes to service provision and 20% will go to administration, which is marketing, the fund, and of course the administrator. And we have actually developed an application to manage the marketing agents, the practices within the city and within the suburbs, so that it is easier then to have patients roving in between and being traced through e-health records and wherever they would have been treated for. But we encourage our members to be treated by the doctor of their choice, somebody that they've chosen to say, I want so and so to look after me when I'm not well. And usually these doctors are doctors who are within the locality. But suppose they go away, they travel, and then they get sick away from the usual area of residence. Then the network doctor who is in that locality is able to manage this patient using the e-health records that the application is able to provide. To an extent that makes, to an extent that the patient is safe, because the service provider will quickly know what has been happening to the patient, and also that if there are allergies that the patient would actually suffer from. And it is also important to know that there's a lot of duplication that goes on when we are working like silos. But when the walls are broken down through the use of ICT, then whatever is happening in my surgery would end up being known by the next doctor, and that makes life a lot easier for that doctor to know he doesn't have to repeat things that were done at my practice, for example. So we as practitioners, I think this is something that has been we have been lagging behind on, and probably repeating tests that will end up being costly. If you imagine 1,000 patients who are repeated a chest X-ray every month, maybe you go for some $25,000, which is going unnecessarily. So we also have a corporate social responsibility, and this is where you guys come in. We are saying we want to partner with the business world and establish linkages and relationships that will benefit our patients, that will benefit our service providers in the process. And if you take for Zimbabwe, for example, we had problems with fuel only a few months ago, and during that period, for members who were who had registered on our scheme, we were able to provide them with fuel using this model. And it's something that can work. We are working with people who can finance solar projects so that we would have power 24/7. I don't think there's any country in Africa that has been spared of power cuts. And if we do experience power cuts in the healthy institutions, it becomes difficult to trace records and stuff, because remember, we are IT based. We want to go paperless. This is where the world is going. So if we do have backup power using solar, then it's something that is going to improve the way we are practicing medicine at the moment. And before you know it, we are also creating employment for people who are into solar solar energy, in terms of installing or sourcing and installing and even maintenance of those facilities, so to say. We want to retool our practices, because we are working with the equipment that is almost obsolete after going through a number of challenges economically and politically, as well as, I'm sure you have noticed in Zimbabwe, people have been talking about anti-sanctions and stuff. They did, cause some havoc. There could be so many reasons why maybe we are in our situation. But I would want to say, I think sanctions also played a part. So we could not retool because of this, the so-called sanctions, or even accessing money was difficult. So if we work like this and there's money that is circulating within the medical field, then the medical sector, then we should be able to really retool. We want to promote constructive engagement with stakeholders. We don't believe going on strike is the way to go. We believe that engagement is the way to go. So when you go on strike, people, especially in the health sector, emergencies will always come, and you may lose some patients who were not supposed to die because you are on strike. So we believe in constructive engagement. But by and large, for this presentation, we want to partner with the like-minded people and organizations to scale up and deliver health to the people right where they live, not in cities alone. Such is the partnership where we can craft with the International Cooperative Alliance Africa, who are hosting us today. Fine. But basically, what we are at Access Health Medical Fund is nothing is cast in stone. we keep learning and improving our products until we know that what we are offering is what people want. And what people want will keep changing. It will also change accordingly. And thank you. I'm sorry for taking too much time.
Thank you, Dr. Enoch, for that well presented medical health, or is it access health medical? I gave you more time because I thought that model should be done by everyone. So that, once we leave the meeting, then Zimbabwe cooperators can know what is available. Thank you very much. Now, Mrs. Beauty, could we get back to you to finalize what you started?
Yes, Dr. Ross, thank you very much. So I think I'll have to start again, and because of the distractions, I think I'll go faster so that we save on time. So my name is Beauty Marimira, Mrs., and I'm the Managing Director for High Ground Legal Aid Society. My presentation outline is got 3 messages, which are what we do: strategic partnerships with health cooperatives and their members, creation of health cooperatives, linkages with the microinsurance companies. So as High Ground Legal Aid Society, we offer legal insurance to individuals, families, and corporates. And we then cushion them on the unforeseen legal issues that may arise. We are underwritten by Cell Insurance and registered by the Insurance and Pension Commission of Zimbabwe. We also offer short-term insurance products that include motor vehicle and travel insurance. So in the event of legal claims, we refer our members to lawyers that are in our network for representation, and then we settle legal fees for the services that would have been provided. So we are in the process of socializing with some of the cooperatives across the country with a view to engage them in strategic partnerships. We also have risk advisor and consulting firm that provides risk management solutions to a number of sectors in the region. So when I was listening to Mr. Duru's speech, he also spoke largely on policies to do with the health, to do with the health cooperatives. So with risk advisor and consulting, I think we can partner well in that regard of formulating policies and maybe crafting some frameworks. My second message is on how health cooperatives can benefit from strategic partnerships with insurance companies. So I'm overall saying insurance companies because that's where we are coming from. So as High Ground, together with other microinsurance companies, we offer comprehensive solutions tailored to suit our chosen markets. And this has been made possible by the insurance regulatory authorities, not only in Zimbabwe, but across a number of countries in the world where microinsurance companies are supporting the lower end of the markets. And it is against this background that we see opportunities for microinsurance companies engaging with cooperatives as they pursue their strategic agendas. Education and awareness therefore becomes key for both individual members of the cooperatives and the cooperatives themselves. So this can be achieved through legal workshops where members of the cooperatives can benefit on legal issues and changes in the dynamic in legal environment. we find out that there's little education in terms of legal issues, and you find people then falling into prey because they don't have this education. A number of cooperative members may not be aware of issues around will writing and inheritance laws, and we believe they can easily benefit from this through effective stakeholder engagement. A lot of people think that when they write wills, it means that they are dying. But actually, research has proved that if you have a will, you actually live longer. So that also comes into the legal issues that I've spoken about. Then additionally, microinsurance companies understand the need of the cooperative's membership and hence can design products that support wellness programs. My third point is creation of health cooperatives linkages with the microinsurance companies. We would like to support health cooperative strategic agenda going forward, and we remain very positive that health cooperatives will encourage its members to focus their engagements in establishing more health centers across the countries. So as High Ground Legal Aid Society, we are happy to facilitate strong linkages between health cooperatives, members, and insurance companies in establishing these health service centers. We believe that it is wisdom in health cooperatives that make it happen or possible for the organization to achieve its objectives. Furthermore, health cooperatives can leverage on our existing relationships with legal service providers to provide drafting and assessment of contracts and reduce costs. You will find out that a lot of people get lost in so many deals because they sign things that they don't understand. So this is where we are coming from, where we are saying the assessment of contracts can be assisted in that regard. We also have strong linkage with a risk advisory and consulting company that can work with health cooperatives in enhancing their enterprise risk management systems across the geographies. I think I spoke about Mr. Duru mentioning about policies. Again, this is where will also come in. As health cooperatives engage with their strategic partners, there is need to also address other soft skills issues that include grooming and business etiquette, which our affiliate associate can also provide to the members. These soft skills issues are very key in any sector because you know, the education that we get at times doesn't teach us some of the business etiquette. So we are saying we can partner with the health cooperatives in that regard. Dr. Rose, let me thank you for giving me this opportunity to share these three messages on this platform. I think I end my presentation on this note. Thank you very much.
Thank you very much, Ms. Beauty. We really appreciate your three messages. And I think everyone or all the operators have learned that you are ready to engage and partner with them, not only in creating policies and frameworks, but also in creating or linking them to these other strategic partners to realize the dream or the goal of having health cooperatives in Zimbabwe. Thank you very much. Our next speaker is Dr. Chivange, something like that. Welcome, Dr. Chris.
Hello, thank you. Hello?
Hello, Dr. Chris. Welcome. Are you just from the theater?
Yes. Allow me to share my screen.
Geoffrey.
Okay. Is my screen not showing?
Yes.
Okay. So my name is Dr. Chris Chivinge. I'm a senior resident medical officer at Linkages Central Hospital in Harare, Zimbabwe. I would want to thank International Corporate Alliance Africa for this opportunity to share my presentation on the Zimbabwe Health Cooperative stakeholder meeting. I would also want to extend appreciation to the to earlier speakers, Mike Duru, Rose Karima, Dr. Enoch Tatira, and Mrs. B. Marimira. So the objectives of my presentation, I wanted to outline the benefits of health cooperative partnerships and steps to launching health cooperative partnerships. So as background, the World Health Assembly 58.33 stipulates universal health coverage and notes of differences between achieving this goal against cost and risk. It also suggests the role that can be played by civil organizations, private sector to mitigate the cost and rise of universal health coverage. So
that sounds great. Thank you, Dr. Rose. Thank you, Mr. Duru, Ms. Beauty. It has been a real pleasure to hear the ideas from everyone. I'm pleased to join you today. I'm joined with my colleague, Mr. Johnson Ndinda. He's joining us from Uganda. Health Partners began as a health cooperative in the United States in 1959. And we've been working in Uganda since 1997. So we're pleased to have this opportunity today to tell you a little bit about how health cooperatives are working in Uganda. And with that, I'll turn the microphone over to Mr. Ndinda, who will explain how health cooperatives work.
Thank you, Jennifer. Please, can you share our presentation? I can still see the presentation from the previous speaker. Okay. Thank you so much, Jennifer. Can everyone hear me? Am I clear?
Yes, John. Yes.
Okay, let's go. My name is Johnson Ndinda. I work as a technical advisor for provider relations. You will allow me not to turn on the video because it also seems to interfere with the presentation, but probably at the end, I'll be able to put on my video. I want to take you through the health cooperatives model, which we are implementing here in Uganda, and my presentation is really from a practitioner's perspective. And we want to look at this in regard to partnership with healthcare providers so that they can meet members' needs. Jennifer, go to the next slide. Okay, that's myself. You can see my address and my picture. Let's go to the next slide, Jennifer. I want to begin by talking about Health Partners, the organization. Like Jennifer has said, it's the largest consumer-governed non-profit healthcare organization in the United States. It created the health cooperatives model to be implemented in resource-poor locations for local stakeholders to be able to access care at affordable rates, but also to overcome their health challenges. Health Partners offers health insurance, healthcare, research, education, and innovative solutions. It runs over 90 clinics and hospitals, mainly in the US, with over 26,000 dedicated employees and 1.8 million insured members. Next, Jennifer. One would ask, why did Health Partners come into Uganda? When did it go there? Health Partners started its work in Uganda in 1997. And in 1999, the first health cooperative was registered. It is called Uganda Health Cooperative Society Limited. And down the road, 20 years down the road, we have seen other health cooperatives get registered in Uganda, as I will be showing you in this presentation. But one would ask, what was the challenge? Why did Health Partners have to go into Uganda to establish this innovation? There was a challenge of high out-of-pocket costs at 41%, and it still persists. And actually, across East African countries, the out-of-pocket cost is above 20%. There was a challenge of patient debt, patients escaping off the hospital ward without paying their bills, patients going for debt from going to borrow from their neighbors to access care. And of course, this debt burden would also be transferred to the healthcare providers, who would get supplies and stocks on credit from the suppliers. Then the healthcare providers were not making enough to deliver the services needed by members. And all that would lead to poor health outcomes. And by Health Partners coming into Uganda to establish the health cooperatives model, it was looking at a solution that would be locally owned and managed by the local stakeholders, like I have explained above. Let's go to the next slide, Jennifer. And one would ask, what are health cooperatives and how do they work? Like Dr. Enoch said, maybe this can work in different ways given the country, but for us, we have defined health cooperatives as registered businesses made up of member groups, other traditional consumer cooperatives, schools, and employee groups who come together and join a healthcare provider of their choice to work in a health insurance partnership for mutual benefit. It is autonomous, owned, and managed by members who elect a board of directors to oversee their affairs. I want to go slow when explaining this so that people can internalize it and try to see how it works. It works based on shared risk, where all members in existing groups, schools, employer groups, other cooperatives choose a healthcare provider of their choice and contribute premiums for all their family members to that healthcare provider, so that any member who falls sick, his treatment cost can be gotten from the pool of premiums that has been contributed by these members. The diagram before you illustrates what I've just explained. We have members on one side, we have healthcare providers, we have boards of directors, and these come together into a partnership that is based on a memorandum of understanding where they have roles and responsibilities to be fulfilled. For example, members pay premiums to the healthcare provider. They also pay co-payment to the healthcare provider at the time of seeking care. In turn, the healthcare provider gives them services that are contained in the memorandum of understanding that is signed. And the care providers employ data entrants to oversee the daily running of the insurance services at the facility. And as you can see on the diagram, the board is chosen out of the members and care providers to oversee the affairs of the health cooperative, to make sure that conflict is resolved, to make sure that quality is enhanced. And members support the board by contributing annual subscription fees or membership fees into a reserve fund. And on the other hand, care providers contribute 10% of the annual surplus into the reserve fund so that the board can have meetings, the board can be able to operate. But 90% of the surplus which care providers earn on the premiums is reinvested into the facilities so that care can be improved. For example, they can decide to buy a new equipment. They can decide to improve on the remuneration of the staff. They can also decide maybe to put a deliverable bed into the maternity wing. And as I've explained, you can see that the model has no third-party managers. Like we know that most insurance companies are about profit making, but this one is member owned. They are about accessing care and quality care. The model is financially sustainable. Like I've shown you, you have not seen any outsider bringing in money. No donor. People collect their money and agree with a healthcare provider to give them a benefits package that can be equivalent to the premiums that they have paid. It is a gateway to reaching the informal sector because we know that people in probably higher organizations could be having access to care through insurance, but people who work in markets and gardens are very hard to reach. So this can be a gateway to reaching them so that they can access care through insurance mechanisms. Next, Jennifer. One would ask, what are the health cooperative benefits? What do people benefit from being in health cooperatives? One, members afford care and access care as quickly as possible. There is no barrier because people have prepaid their premiums. All they need is to have a member identification card and go to the facility as soon as they feel unwell. And because of this, the healthcare providers also try to health educate members and give them preventive materials. The members go when the disease has not progressed, and this leads to improved health outcomes. Then the other thing is that members do not miss work because of illness. They don't miss many days. And members who are in schools or in the teaching profession may miss less school, like the teachers and the pupils. Then on the other hand, the care providers benefit from steady income. The prepayments which members make in the groups and cooperatives help the providers to prepare early by stocking up the drugs, by bringing in the other laboratory implements, by paying their workers on time. So this helps the providers to work when they are well facilitated. And the healthcare providers receive members who are not very sick, and for that matter, they use less resources on treating them. And all this leads to improved quality. And the relationship between the community and the healthcare givers is improved because of the constant interaction that the healthcare providers put on their members to see that they are healthy. Let's go next, Jennifer. So one would ask, what is Health Partners' role? Because as I talked, we had not seen what Health Partners is doing, but now here we come. Health Partners is a capacity building organization which tries to promote sustainable development. So our role is to train trainers in health cooperatives administration, in board governance, finance and accounting, data collection and analysis, so that decisions can be made based on data. If providers are not working well, they have to go back to the data and try to look for where challenges could be coming and use that data to take decisions. Then Health Partners builds networks between and within cooperatives, like we are talking about introducing health cooperatives in Zimbabwe. This would be part of our work to build the networks, then between healthcare providers, boards of directors, and local businesses. As you can see, there are no subsidies. Health Partners does not top up on members' premiums, and it does not even cover the cost of treatment incurred by members to the care providers. Because that is not sustainable, we have evidence, we have not seen it work, we have ever tried it before, it didn't work, and that's why we emphasize it, as you can see on the screen before you. Next. What has been the impact of health cooperatives over the years in Uganda? In a study done by Makerere University School of Public Health in 2015, the following results were established. Members in health cooperatives were better protected financially. They were found to have adopted preventive behaviors. They were seeking care earlier, and they were not selling off their assets to access care. And on the other hand, the providers who were serving health cooperative members, who were working with health cooperative members, were earning an increased earning out of their service to the members. Their cost recovery was higher compared to those who were dealing with non-cooperative members. Let's go to the next slide. Let me give you an in-depth of the results that I've just talked about. For example, on financial protection, the study compared cooperative members against non-members, and on the issue of borrowing to access care, it was found out that 23% of cooperative members borrowed compared to 46% of the non-members in order to access healthcare. You can see the gap was twice as much. And when it comes to paying for care on credit, it was found out that 15.5% of the cooperative members were less likely to have used credit to pay for healthcare compared to 29.4% among non-coop members. And the study also established that 34% of coop members sold off their assets to access care, but this was against a huge 78% among non-cooperative members. Next. There was also the issue of preventive behaviors, which was sampled, and 3 areas: hand washing stations in homes, sleeping under bed nets by children and pregnant mothers. As you can see, among homes of cooperative members, up to 80% of the homes had hand washing stations among coop members, compared to 66% among non-coop member homes. Then over 90% of children and pregnant mothers in homes for cooperative members were sleeping under bed nets, compared to the low percentages shown there among non-coop member homes. Next, we look at incidences of illness. What was found out during that study? Incidences of illness were far higher among non-coop member homes or people who were going to the facilities, at 34% compared to 29% of members who were getting a fever. And then 19% of coop members were less likely to get a diarrhea compared to 28% among non-coop members. And even the treatment-seeking behaviors among non-members were far higher compared to treatment-seeking behavior among COP members, because the COP members were not having any barrier stopping them from seeking care as early as possible. Let's go next, Jennifer. On provider cost recovery, this is the difference between the revenue care providers collect against the treatment costs that they put on members or patients. When care providers were working with insurance members, they earned around 19,793 Ugandan shillings, which is an equivalent of $5. And those who were treating out-of-pocket patients, non-members, were incurring a loss of 1,565 Ugandan shillings, which is about 40 cents of a dollar. So treatment of a patient who is a member was more profitable to the care providers compared to treating out-of-pocket patients. Next, Jennifer. Let us look at results of the previous project that Health Partners implemented in Uganda. Can you hear me?
Yes.
Okay, results of a project, cooperative development project that Health Partners implemented between 2011 to 2014 brought in amazing results in the country. Over 46,000 members were enrolled into health cooperatives. They were accessing care through health cooperatives, and they were being served by 31 care providers. These were registered under 14 cooperatives and pre-corps. When a care provider is offering health insurance services but has not yet registered as a cooperative, we refer to that as a pre-corp. So those were the cooperatives that were giving care to people during that period, and we are building on that work. In 2017 alone, the provider surplus earned by these health cooperatives was around 372,880,000 Ugandan shillings, which is about 100,000 US dollars. And life of project surplus within those 6 years was over 1 billion, and that is about 300,000 US dollars. So as you can see, the care providers who are working with health cooperative members and far better compared to those who are not working with health cooperative members. Next, Jennifer. The current project we are implementing will run through to 2023. And in the 3 years that we have so far worked, we have seen increased demand countrywide. 6,000 members have been enrolled into health cooperatives, and these are working within 16 new healthcare providers. We have seen improved reporting and accountability among health cooperatives. As you can see on the map before you, the work I have been talking about began in southwest of the country, where you see black dots with a few yellow dots. But we have been able to expand to the northeast and central of the country, as Jennifer is showing with the cursor. And the health cooperative movement is widening in Uganda because of what I've just explained about increased demand. Next, Jennifer. There has been challenges. We can't say there has not been challenges. One, we have seen dependency. Most group members or community members would really want to be supported with premiums. Healthcare providers would want to be supported with money for treating insurance members. But like I said, that has not been sustainable. We tried it before, but it didn't work. So where is the solution? The solution is in results-based financing and investing in cooperatives that want to invest in their work. There has been a challenge of lack of skills needed to manage health cooperatives. And like I said, our work as health partners is to make sure that we build capacity. And we have been training cooperative coordinators, cooperative trainers. We have tried to reduce complexity of training tools in the model. And we have tried to see that there is networked skilled professionals who are linked with less skilled professionals. And there has also been a challenge of cultural norms and hierarchies which reduce enforcement of insurance principles. When care providers and group leaders don't enforce insurance principles, they fail. And so we have engaged the leadership, and we have also invested in behavior change communication. Those are the solutions that can really fight cultural norms that weaken insurance principles. Lastly, we have seen low awareness about importance of health insurance. In our country, people find it easier to join a barrier society where I fall sick. You don't come to see me on the hospital bed, but when I die, you contribute money towards my burial. And sometimes I don't benefit from that money. It buys meat for people who are on the funeral. It brings in a tent and chairs. And then we say we have sent you off when you suffered and we couldn't help. So we want to try and increase awareness on the importance of insurance through radio and poster campaigns, leadership sensitization, because if the leaders are not leading, then the community will really not see much trust or sense in what we are talking about. Then we also promote peer-to-peer discussions, which sometimes bring about individual change. Next, Jennifer. What are the implications? We know that the challenges to access to health care can be overcome through universal health care coverage. But this is not attainable in Uganda and in many parts of the world. But as a country, we have been trying to enact the National Health Insurance Scheme, and this is still failing to be enacted. But still, we know that it can probably reach the formal sector, those people whose payroll can be easily accessed. It can subsidize the poorest of the poor. And already, the government gives free services to the poor of the poor. But sometimes they find there are no drugs there. And the National Health Insurance Scheme would rely on tax revenue and government funding. And many times, we hear some unfunded priorities in government, and probably the National Health Insurance Scheme would also be facing some of these challenges. But one of the other ways we have seen that universal healthcare coverage can be attained is through health cooperatives. Why? They can easily reach the informal sector, those people who work in markets, in gardens, the people who work in tax parks, people who are working at low-paying jobs. All those people, we categorize them under the informal sector, and through health cooperatives, through the already existing cooperatives and groups in which they work, they can be easily reached. The health cooperatives use low technology. We don't encourage health cooperatives selling smart cards at 50,000, at maybe $10. No, the health cooperatives are locally owned and managed. As I explained before, you have not seen a third party managing the health cooperatives for anyone. And for that matter, they don't really run for the sake of earning profit, but for the sake of enabling members to access care. Then Because of this provider-member partnership, there is drive for quality. The MOU that is signed between members and providers and the presence of the board of directors ensures that quality issues are reported and resolved. Then lastly, the health cooperatives incentivize improved health outcomes. Next, I'm about to finish, Jennifer. What difference have cooperatives created? One would want to know the difference that health cooperatives create. One, there is local ownership. The people are taking charge. The stakeholders are taking charge of what they want in their health cooperative. It has financial sustainability elements about it, as I illustrated on the diagram of how health cooperatives work. It is not run by third-party managers who are motivated by earning a profit. It really leads to quality because the members hold the care provider accountable for quality issues. And then it promotes early treatment-seeking behaviors because the moment a member falls sick, there is no barrier. The prepaid premiums are there to cover any illness that has been agreed upon and documented in the MOU. Lastly, Jennifer, I want to thank you for listening to me, but here are questions probably that should trigger a conversation. And your questions will also be welcome, but mine are, do your cooperative members have access to care? Look within the cooperatives that are already existing in Zimbabwe. Are those members there having access to care? Would health care increase productivity if your members are falling sick less often? Would they work more and increase their productivity? Would insurance protect your community members against selling their assets so that they can seek care? And lastly, what can you do to make health insurance an option for your members in your community? I thank you so much for listening to me. Over to you, Dr. Rose and Jennifer. Thank you everyone for listening to me.
Thank you. Thank you, John. Thank you, John. When do we answer the questions? Now or later?
I think we can answer them now, given that we have less time. Members can discuss them.
Okay, so the floor is open to answer the questions John gave and any other question that you may have. Then after that, we can have Dr. Chris, who got lost, but is now found. You can raise your hand, then Geoffrey can ask you to talk. Do your cooperative members have access to healthcare? Mike Duru.
Yeah, Rose.
Yes.
I think, like in my welcome remarks, I made it clear that we do not have even a single cooperative in the health sector. So, as you know, that cooperatives, by their nature, most of them, they are people with low incomes and none incomes at all. And these are on the vulnerability level. Even if we are to share with you what we got in 2017, that 80% of the people who were tested for HIV/AIDS and came out open were able to remove stigmatization. 80% were from those that are non-earners and part of them cooperatives. That tells you that these people, of course, besides being vulnerable to society because of their status, cooperatives, they don't have enough money to access health care. what is needed, like the presentation has shown us, is to vigorously for us in Zimbabwe to mobilize members to start such a very good initiative, where we need to come up with cooperatives in all sectors, in all centers, be it in urban, in growth points, and deep in rural areas. I think this is where we are missing it. We just think of those that are in the urban as people who need care. But if you get statistics of people who are dying for lack of care, medical care in rural areas, surpasses those that are in town. So we need to reach out there. If you listen carefully from Dr. Tatire's presentation, this can equate health partners in Uganda. His model suits very well into this. Together with Marimire's insurance coming in, I think we can assist our members to access health so that they increase productivity in their cooperatives.
Thank you, Mike. I think you've answered all the questions. Anyone else with different answers to the same questions or something else to talk about before we ask Dr. Chris to finalize his presentation? Silence means Mike has talked about us all. Oh, Johnson has raised his hand. Johnson, go ahead.
Thank you, Dr. Rose. We also want to get questions from the members on this meeting, because my questions were just to probably try to help us see what is happening in other areas by members sharing their experiences. But those who have questions are also welcome. Thank you.
Okay, I think we can take that after Dr. Chris has spoken, so that then the participants can ask all the speakers questions. I don't know if that sounds good for you, Johnson?
It's okay. It's okay. You're the leader of this meeting, Rose.
Yeah, today I'm the boss. All right. Dr. Chris, I think we left you when you're giving us the outline and you had begun with the benefits. Could you continue from there, please?
All right. Also, I'd left on the benefits. Okay. Allow me to share my screen. All right. You can hear me clearly?
Yes.
Very well.
Okay. So I reached the benefits of healthcare cooperatives. Their importance is in assisting government to bridge gap between cost and the expenditure to realize the sustainable development goals. The consumers are able to access health for all by pooling resources for those in need. Providers are able to deliver quality healthcare through modest infrastructure, technology, and human resource. Financial cooperatives are able to risk insure patients as health is unpredictable and to mitigate out-of-pocket expenditure. What are the benefits of the benefits that I have outlined above? So the population is entitled to quality healthcare. That is the consumers and the providers. They are more likely to have stronger health institutions in terms of infrastructure, consumables, and healthcare providers. This also comes with the question from the last picture. The last speaker was talking of does a healthy population entitle to productivity? I actually think a healthy population, it means more resources are channeled towards productive sectors, and the people who will be in the productive sectors are able to do to carry out their mandates without any hindrances. So all this entails universal coverage for also health cooperative partnerships must be endorsed. Then the other objective was to steps to launch a health partnership cooperative. So I think first of all, the legislation is very important to not like the first what Mrs. Marimire was saying about legal advice, that when you want to launch a health partnership, you should be able to do it in line with the laws of the governing country or community. Then also on the legislative part, there is need for a constitution from the cooperative, so that the cooperative is has got some guidelines so that they remain goal-oriented. Then another step to launch is what type of cooperative it has to be. I think they have to clearly state whether it is mainly going to consider consumers, healthcare providers, financial cooperatives, or multi-stakeholder cooperative. Then what is the target population? I think from Dr. Tatira and from the last speaker, they outlined their target population and the resources that can be harnessed. Then from the last speaker, he had the question to say what is the resources. The last question, I think it was to do with what can you make health insurance an option for your members or in your community, and also Mike Dured talked about that we do not only have urban people. Some are formally employed, some are informally employed. So for the formally employed, they might be able to subscribe every month in terms of monetary issues. And those who are informally employed, there should be a narrative to say, for example, those who are farmers, cooperatives, they should be cooperatives that encompass what they have. Let's say at the end of each farming season, you provide, for example, half a ton of maize, so that you are insured for the you insure with the resources that you have. That is my point where I said cooperatives should be able to harness resources that are population dependent rather than being cooperative dependent. Then in conclusion, the points which I think are important to be addressed by people who want to establish and the current people who already have these health cooperatives, good and proper communication, stakeholder participation. They should be able to address change and uncertainty within the socio-economic status of the people, and they should be able to, when they are launching, to address future unforeseen conflicting concepts and the current conflicting concepts if present. Then what I believe that is what is the population looking for in conclusion? The population is looking for affordable cooperatives that accept resources that are at their disposal. The population is looking for real value for the resources that they would have dispersed. The population is also looking for transparent and accountable health cooperatives. So that's my presentation. I would want to thank you.
Wow, thank you very much, Dr. Chris. We really appreciate your patience and also getting lost and coming back because of technology.
Yeah, all right.
At this moment, may I give apologies for Dr. Dan. When he was in session, an emergency occurred, and being a doctor, the other patient doctors, he was called for an emergency. And I think the presentation we wanted to make was just their experience as a cooperative of health workers in Uganda. That's what they do as doctors and other medical professionals. They came together and formed a cooperative that is providing healthcare to both their members and also to the community. Now, at this point, I would like to invite questions for all the speakers that have been speaking today. Then after that, we can discuss the questions and then forge a way forward. The floor is open. Geoffrey, can you see any hands up?
No, there's no hand up.
We
If you
got
don't have
it.
any question, okay, where is the question? Oh, from Mike. Okay.
No, I'm saying we got the presentation very well.
Okay, okay.
Yes.
Thank you for that. So could we assume we have no questions? Then I would ask each of the speakers present to give us their last one. And then Jennifer, would you be kind enough to conclude for us? And then we have Mike Duru giving us the way forward for Zimbabwe. We begin with the first speaker, Mrs. Beauty. You are still our first speaker. Your last word. You are mute. Mrs. Beauty is mute. Maybe before she unmutes, can we have Dr. Enoch? Your last one, please.
Thank you very much. I'm quite happy and a lot relieved. I mean, from learning two things from today's interaction. I mean, I realized that what I was trying to do.
Okay.
This is Beauty. We're having Dr. Enoch and then you come later. Sorry.
Okay, so I was saying what I have been trying to do in Zimbabwe is already being done elsewhere. So I'm quite happy that I am not really, running my own battle or maybe fighting my own war. I mean, other people are already doing these things, so we can actually exchange, opinion and way forward. Then the second thing that I want to say from my presentation that I probably left behind is that in our arrangement in terms of the governance and distribution of resources, we are saying everyone would eat what they kill. So, I mean, from the people who are marketing our fund to people who are managing, they actually work on commission, and the commission is supposed to end up with a maximum of 20%, so that we leave 80% of whatever is collected towards the resourcing for services that we would want to offer in the community. And that if that happens, at least we know quite a sizable amount of money will be circulating within the health sector, as opposed to what is happening at the moment, where money is circulating within the houses of fund managers, and you can't reach it no matter what. At the detriment of offering a service to the communities that we would want to serve. And when that happens, we are defeating the efforts of the members who are contributing, to the effect that they would rather buy things that would work for them. For example, when they die, they would want to buy funeral insurance at the expense of buying some medical insurance, which is supposed to cover them during their life. I've heard earlier on that some people end up maybe even providing more than what was enough to cater for the expenses of managing a patient who would have died at a funeral, because people were not willing to contribute. We are seeing these things even locally, and I think this is something that we need to educate our people so that they also understand that it's better to live a healthy life than to be sent off in a casket with thousands and the thousands of dollars when people fail to get some maybe some $20 or $100 to buy you enough medication to make sure that you are living as well. Thank you very much for listening to me. I've shared my presentation. I've shared my presentation with the ASIRA. I think I mean if people would want to have it, yeah, sure. I'm more than happy to to share it and then maybe then comment on whatever they find interesting, so that we can talk going forward. Thank you very much.
Thank you very much, Dr. Enoch, for really offering your expertise and presentation to us. We thank you. Mrs. Beauty, can you unmute?
Oh, thank you very much, Dr. Rose Karim, and all the members that were present in this presentation. To me, I don't have much to say, but this presentation was quite an eye-opening. I've quite learned a lot from all the presenters. Very much, and hope discuss this presentation. This meeting.
Looks like you're disconnecting, or is it on my side? I don't know.
She's breaking.
It's from my side.
Okay. Okay, then we can move on to Dr. Chris. Dr. Chris, thank you.
Oh, so I wanted to say in conclusion that there is real need for health cooperative partnerships, especially in Zimbabwe, because the healthcare system is not well funded by the government. So in just conclusion, I just wanted to highlight that there is space and there is real need to educate people and to motivate them to join health cooperative. Thank you.
Thank you very much, Dr. Chris, and for concluding with that, the need is there, and the opportunity then exists for the cooperative movement in Zimbabwe to leverage on the partnerships presented so that the health cooperative model can be effected in Zimbabwe. Next, we shall have Johnson and then Jennifer.
Thank you, Rose. I was happy to be part of this meeting and to share experiences of what we have seen happen in Uganda among communities where the health cooperatives model is being implemented, because households in some areas have really been able to save money to do other investments in their homes. And we have also seen care providers, especially those which are mission-based, church-founded, and private practitioners like Dr. Tatira, be able to sustain their businesses because of working with health cooperative members. And so I would really call upon you, those who want to see change in their country and as far as healthcare access to care by community members is concerned, to read further on this and look into ways how it can be implemented for the benefit of your communities. I thank you so much for organizing this, Rose, and your team. Thank you so much, and have a good evening, good morning, wherever you are. Thank you.
Thank you, Johnson. We also really thank you, especially Health Partners USA and Uganda, because we always call upon you to spread this bushfire, because according to me, this will be a bushfire. Once it starts in these countries, then all the countries in Africa will take it up. Thank you. Jennifer?
Thank you, Dr. Rose. I love your vision and I share it. It was wonderful to hear all of the presenters today. There are so many good ideas, and we know the need is there in Zimbabwe. The journey of 1,000 kilometers begins with the first step. So in concluding, I'd just like to encourage everyone on this call to find partnerships, to connect with each other and those who have shared goals, to start to plan the next steps to increase access to coverage to healthcare in Uganda. So together you can start with one member and really improve quality and access and solve some of these challenges we've talked about today. So many good ideas, so many great leaders. Let's come together to start to create the change that we want to see. Thank you very much.
Thank you, Jennifer. We come together to create the change that we want to see. And I remember Dr. Tatira saying that if you carry your own water, you know the value of every drop. So I think the Zimbabwe cooperative members, let's carry this water. We are calling health cooperatives, and then we shall know the value. Mike Duru, conclude for us by giving us the way forward for Zimbabwe on this matter.
Thank you, Dr. Karim. For me, I think we just have four steps. Step number one is awareness, because already we have a lot of cooperatives that are in Zimbabwe. So what we want is to discuss with them so that they diversify from perhaps the agriculture work that they are used to, the housing work that they are used to then say, can we also have to register ourselves in the health sector? My second point is policy check and advocacy. What are the policies along this sector or within this sector? What are they speaking to? Do we have a room as cooperatives to participate? If there is room, it's okay. If there's no room, it is an opportunity for us then to lobby and advocate for what we think is good for us to participate in the sector. This I also say I'm so happy that I already have got technical partners in the name of Dr. Tatire, Dr. Chivinge, and Madam Marime. Their experience and would add a lot of value as we push for policies that are relevant to cooperatives to participate in the health sector. My third point is training of members to understand this trust, not only members, also government officials where cooperatives are being registered, must also be trained at the same wave as we start our journey, which has to start with a zero, like Jennifer is here. Then the last one is automation of health cooperatives. At this level, I also look at the partners like the doctors we have today. We had today on this platform. They must form part of our technical committee to help us do the right thing, because this is a new field that we want to venture into. But with these people that have shown their zeal to participate at this initial stage, we will definitely need to rope them in as we try to form these cooperatives. I want to give ourselves next year up to mid-June, we would have come up with 2 or 3 cooperatives in Zimbabwe. We know how to do it. And I also urge you, Rose, to keep on reminding us where we are as a country in terms of formation of these cooperatives by June 2021. Thank you.
Thank you, Mr. Duru. You just told somebody who knows how to push. I'll push you. And June 2021, we need at least 4 cooperatives. I think this is a great way forward, and I believe with the training, you have the capacity building people, the health partners who are always willing and ready to build capacity in every region of Africa. So thank you so much. I do not know what to say, but I can only say thank you. Thank you everyone for participating. I think at this juncture, we can call it a day and be very happy that health cooperatives are started in Zimbabwe. Thank you everyone. Have a good evening. Have a good day, Jennifer, and everyone else. Thank you. We can't wait to hear more stories from Zimbabwe.
Thank you, Dr. Karim.
Thank
Thank you.
you.
Bye.
Thank you.